Hi there, my name is Coolsjes Singhvi, and I'm a ninth grader at Stillwater Area High School. My project is the modeling of blood glucose to optimize diet and exercise for type 2 diabetes management. Here's my abstract. I have this attached to my paper and project. Here's my introduction. Type 2 diabetes is a serious chronic disease affecting many people. However, it can be managed by controlling the four pillars around it: diet, exercise, medicine, and blood glucose measurement. According to the Center of Disease Control and World Health Organization, we can halt the rise of diabetes by 2025. It will happen through machine learning, which has shown some promise in glucose prediction and lowering it. However, when tested, the prediction accuracy was very low for any effective type 2 diabetes management, and blood glucose readings were not taken at the same time daily or at the same time for every patient. A more robust and accurate type 2 diabetes model could be developed using continuous glucose monitoring and more detailed nutritional and exercise inputs. The research objective is to create a model that's over 85% accurate to predict blood glucose levels using the four pillars. Here's my research hypothesis. Here are my methods and materials. It's a continuous blood glucose monitor, which measures blood glucose levels every 15 minutes for 14 days. An Excel spreadsheet to store and analyze data, Python and Google collaboratories, and a driverless AI software from H2O AI. Here's my Clark error grid. My goal is to get my model in zone A or B of the Clark error grid. Zone A means that the research is clinically accurate. Zone B is clinically passable. Zone C is on the verge of being clinically passable and not. Zone D and E means it is clinically inaccurate. Here's my nutritional, exercise, and pharmacology data captured for the study. For food, it was the type and quantity of it. For aerobic activity, it is the amount of time on a treadmill. For strength exercises, it is the amount of time doing them. For medications, it is the amount of type 2 diabetes medications prescribed. For supplements, it is the amount of vitamins or other supplements taken. And for steps walked, it is based on Google Fit data. Here's my nutritional lookup table. For food, I divided it into categories based on individual nutrients. But not all foods have a food label. So I went to a site called Nutrition X, which gets their data from the United States Department of Agriculture, and used that to calculate the food. Here's my daily data and exercise input table. Here's the heat map of different parameters. In white or light orange, it means that their parameters are strongly correlated. In purple or magenta, they are not correlated, and in black, they are negatively correlated. For instance, aerobic and anaerobic both have a black when shared with the average glucose, which means that they lower the glucose, while something like artificial sugar will raise the average glucose levels. Here's my correlation graph and my radar plot when scaled to 1. The bolder the line is, means the more correlated the points are. Here's the linear regression model used. As you can see, there are 3 of them, with the most accurate being the all parameters model, having a root mean squared error with a comparative factor of 13.87. Here's my AI setup screen. Here's the setup screen that I used to input data. And here's the output, where it will calculate my root mean squared error. Here's my machine learning models using the training data. I used 4 and it was accurate with the light GBM model with genetic algorithms, but it only had 4 parameters: strength, caffeine, artificial sugar, and fiber. And its root mean squared error was only 14.972, meaning that the statistical model was more accurate than the machine learning model. Here's the comparison between the training and validation data set. One thing to note here is the standard deviation. The more of it is worse, because more standard deviation means more range in data, meaning that the data is less accurate and precise, meaning that less standard deviation means more accuracy. As you can see, there is a huge difference between the glucose levels on the training data and the validation data, meaning that this was effective. Here's my table t-test with 2 samples assuming unequal variances. The alpha value was a little higher than the p-value, meaning that the 2 means were statistically different. Here's a personalized equation for the all parameters model. Of course, as different people use this, they will all have different mm, equations as we are all different. But that is very accountable for as it is a linear equation and we can be changed very easily. Here's the daily blood sugar variation by the hour for the training and validation data set. Blue is the training data and the orange is the validation data. And it is a clear difference between these two lines. The vertical bars are the standard deviation error bars, the blue for the training data and the red for the validation data. Here's the comparison of the daily average of the continuous glucose model versus the model for the validation data set. As you can see with the points, the R squared value comes out to be 0.996, the highest ever achieved. Here's the solver setup and a Microsoft Solver constraints and optimized value. Here is the minimum and maximum values recommended by the CDC and American Diabetic Association. Here is the ones optimized for a blood glucose level of 155, and here's the minimum and maximum achievable. For important research achievements, medication was lowered and calories were doubled, yet blood glucose and A1C levels both went down significantly by 15.7 and 12.6% respectively. Compared to other research, the root mean squared error, the comparable factor was a lot lower, 13.87 versus 21.5 on other models. The parameters were a lot different, and the model complexity was a lot simpler, a small simple linear equation versus a machine learning model. The Clark error grid. For mine, they were 100% in zone A, while others were only 69.3 to 84%, 3% there. There were some sources of error in my model, so Google Fitness doesn't give an accurate measurement of steps walked, as this is a smartphone-based app on a phone, and people don't carry a smartphone with them everywhere. A fitness band would be a better tool to use in the future. There's an inherent measurement errors for food portion size estimates, and overall, the food breakdown was not an accurate reflection of what the person actually ate. Also, it was uncooked or raw food. When food is cooked, added ingredients like cooking oil, spices, onions, and garlic were added, but these weren't calculated in the overall nutritional breakdown. Physical exercises were not accurately recorded, as when a person is working out for 30 minutes, it's just like that they were working out for 30 minutes straight, but could mean different things. They could be working out for 30 minutes straight, or they could be working out for 30 minutes, but take a break every 5 minutes. Intensity was also not measured, it was just sorted into aerobic and anaerobic. So for future size, activity points could be a better measure. Continuous glucose monitoring devices have 9.7% error rate as compared to finger prick readings. The error at the beginning and the end of the sensor cycle jumps to around 14.5%, but we don't know if that is canceling or adding to the continuous glucose monitor error rate. Therefore, we should try to research to see this, as well as calibrate it against the finger prick method for each person taking part in the study. There's also additional parameters that affect blood glucose levels, like mood, sleep quality, stress, additional supplements like cinnamon, meal timings, and physical fitness timings. Some of these are difficult to measure and others are subjective, but further research could include some of these, as they do affect blood glucose levels. The research could expand to multiple subjects rather than just one, see if the accuracy carries over. The study should be continued for about 3 months, and a smartphone model application should be developed for easier tracking and prediction. But in conclusion, it was possible to develop a model that was very accurate based on nutrition and exercise. Of my 4 hypotheses, 3 were correct. The one that wasn't was on statistical models being more accurate than machine learning models. This is probably so due to the linear response of blood glucose to most of the parameters used in the study. But overall, a simple model can make a huge difference in the cost of type 2 diabetes management for both type 2 diabetes and prediabetes patients. Here are the references to my project. Now, let's look at my source code. Thank you for your time.